Hello again, and welcome to our discussion today on antifungals and antiviral agents. We'll be discussing several agents. However, for the antiviral section, it's beyond the scope of this course and this lecture to discuss antivirals used to treat hepatitis C, and we also will not be covering the antiretrovirals for treating HIV. Those two topics are specialized, and if you wind up in a practice area that uses those frequently, that's something you'll become more familiar with there. So with that, let's get started on discussing antifungals and antiviral agents. Our objectives for this lecture are similar to those from the Antimicrobials 1 and 2 lecture. However, we have focus on antifungals and antivirals. So again, focusing on the spectrum of activity for these agents, identifying practical clinical issues such as drug interactions, adverse drug reactions, and deciding when it comes to influenza, since that's such a prominent disease state in primary care and acute care, deciding whether treatment with an antiviral or prophylaxis of spread with an antiviral is indicated in a select patient. And finally, then selecting an appropriate treatment or prophylaxis regimen for seasonal influenza if we do decide that it is warranted in that patient. So we'll get started with our antifungal agents. We'll begin with the azole antifungals. You're probably familiar with fluconazole, which is the most widely used of the azole antifungals, used very frequently in the outpatient setting for candida-related infections. As a class, the azole antifungals inhibit fungal cytochrome P450, and this essentially then reduces ergosterol production, and the fungal cell then cannot survive. So the agents that we'll cover or touch on today include fluconazole, itraconazole, and voriconazole. Two agents listed for you that we won't cover, but just so that you're familiar with them being out there, are posaconazole, which is often used for prophylaxis in bone marrow transplant patients, and isavuconazole, which really has sort of a niche for aspergillus or mold infections. It's the newest agent on the market right now. And there are many others like miconazole, turconazole, etc., that are available in topical formulations, some of those being over the counter for the treatment of vaginal yeast infections. So those I'll leave for your self-study. So in terms of sort of the pillar of the class, fluconazole, I think if you can remember that its spectrum is Candida species, but it does have a couple of big misses. So it's great for Candida albicans, Candida tropicalis, Candida parapsilosis, and Candida lusitaniae. And however, it does not cover infections due to Candida glabrata and Candida krusei. So if you would get an isolate back that was one of those two and your patient is on fluconazole, you could look at the susceptibility patterns. In some cases, we have what we call a dose-dependent susceptibility for glabrata, especially. If we push the dose high, we can still achieve a good outcome. However, for empiric use, we would definitely not use it without susceptibility information for those isolates. There's also a role for fluconazole in the treatment of cryptococcal infections and coccidioides infections, and those are more of the endemic fungal infections. Cryptococcus is endemic to the Midwest. Coccidioides is more endemic to the desert Southwest. In terms of practical clinical issues for your consideration for fluconazole patients, it does require dose adjustments in patients with impaired renal function. So you want to make sure to have an idea of whether patients should be on lower doses or at more prolonged intervals. I more often see fluconazole underdosed in the inpatient setting. So we see small doses of 1 to 200 milligrams when really we should be giving these patients larger doses. In terms of pertinent adverse reactions, you can see a rash. QT prolongation can occur with fluconazole, typically at larger doses above 400 milligrams, and if the patient is on other QT prolonging agents or perhaps has potassium or magnesium imbalance. Because these are hepatically metabolized, we can see an LFT elevation. And a very rare side effect that is seen is alopecia, typically seen at high doses and typically reversible with withdrawal of the agent. In terms of pertinent drug-drug interactions, cytochrome P450 inhibitor, and so again at higher doses we see a greater impact, and this can cause an increased INR for your patients who are on warfarin. So you want to make sure to have good monitoring for these patients. The next agent we'll talk about is itraconazole, which is slightly older than fluconazole. It is available orally only. Fluconazole is available IV and orally, but itraconazole is available only as a PO capsule or solution, and the dosing of these are not interchangeable. Because of differences in bioavailability, it's not a one-to-one dose conversion. I'm not going to hold you accountable for what that dose conversion is, but I do want you to remember that if you'd be changing somebody, you need to look it up, and it's not just a one-to-one conversion. In terms of spectrum, it's the same as fluconazole, but you gain some aspergillus coverage. Itraconazole was actually the primary step-down therapy option until voriconazole became available. Itraconazole has some clinical issues that we'll talk about on an upcoming slide that makes it a little bit less attractive than for voriconazole now for treating aspergillus. It also covers many of the dimorphic fungi, such as histoplasma, again, which is an endemic fungus to the Midwest, to the Mississippi River Valley. And you may see it used also to treat tinea infections. Itraconazole is often seen if you have a patient that presents with tinea. In terms of some practical clinical issues, there are a few pertinent drug-drug interactions. Most of them are based on the CYP450 inhibition. It's actually a stronger inhibitor than fluconazole, so we do see the risk for more drug-drug interactions with itraconazole compared to fluconazole. It has the same INR potential elevation if given to a warfarin patient. And if you have someone who's on acid suppression agents, so H2 blocker, a proton pump inhibitor, the GI acid suppression agents can actually cause an inhibited absorption of the capsule formulation, but they don't have as great of an impact on the oral solution. Itraconazole as a whole, whether it's oral capsule or oral solution, is more poorly absorbed than the other azoles, and that's one of the reasons why it really has fallen out of favor. It's sometimes difficult to get good drug concentrations. For that reason, I'd say that you'll see most of your patients on it for a significant therapeutic reason, such as potentially prophylaxis of fungal infections post-solid organ transplant. Those folks are typically on the solution. There's better absorption. If they're on acid suppression, it's less impacted. If you're treating a tinea infection or potentially an onychomycosis patient, then you may see the capsules still used. Another thing that's a little interesting, I think, about this drug is that it does have some negative inotropic properties. So it's actually recommended to be avoided in patients with advanced or unstable heart failure because it can cause some negative inotropic effects. And so if they already have a low ejection fraction or they're somewhat fragile, this can potentially tip them into an acute failure. And finally, like fluconazole, because this is hepatically metabolized, it can cause an elevation in LFTs and hepatotoxicity. Switching now to voriconazole, it's available in both the IV and PO form. And when you think of its spectrum, it covers everything that fluconazole does, plus it also covers Candida krusei well empirically. It still is an empiric miss for Candida glabrata, however. So again, we wouldn't want to use it unless we had susceptibilities. The big gain with voriconazole is good aspergillus coverage, and it does cover some other molds. This one has an interesting site gap. Because it does have such extensive hepatic elimination, it's unlikely to be effective for the treatment of candiduria. So if you do have a urinary tract infection with a Candida species, obviously if we can, we'd like to use fluconazole first. Voriconazole, because of the low concentrations, really isn't as effective of an agent. It has a few significant pertinent adverse effects that are worth noting. Like the others we've discussed, hepatotoxicity is possible. QT prolongation should be on your radar, again, especially in patients who are on concomitant QT prolonging agents. And we can see patients have some visual changes or complain of visual changes, which can be dose related. Therefore, for patients on prolonged therapy, so for treating an aspergillus patient, they should be getting baseline eye exams and periodically while on therapy. In terms of pertinent drug interactions, again, this is a very potent CYP450 enzyme system inhibitor. If you look at the prescribing information, there's a whole list of contraindicated drugs. I won't hold you accountable for memorizing those, but rifampin is one that's worth noting. And some actually in the prescribing information actually has information on how to dose adjust on the front side for patients on certain other medications. So an example would be if you do have a patient on phenytoin for seizures, they recommend increasing the initial voriconazole dose to 400 milligrams rather than 200 to 300 milligrams. So the bottom line for this is patients should carefully be screened for drug-drug interactions before voriconazole is prescribed so that we can ensure that they have the most adequate dosing regimen. And again, since this is used most often to treat active infections such as aspergillus, we want to make sure that we have adequate levels. And we can do drug levels on both itraconazole and voriconazole, and you may see those lab results come back. Shifting now to another class that's used for treating Candida infections, and it's the echinocandins. The nice thing about this class, to help you remember what it covers, is that the word cand or candida is sort of ingrained in the name. The agents that are in this class are available IV only, and they are caspofungin, micafungin, and anadulafungin. And most health systems typically have one of these three on formulary, so you'll be using one of them most of the time in the inpatient setting. In terms of how these drugs work, they inhibit fungal cell wall synthesis by inhibiting a component of that cell wall, which is 1,3-beta D-glucan. And as I already mentioned, they're only available IV, so that somewhat limits their arsenal scope. As mentioned, think Candida species, including Candida glabrata for the echinocandins. They do have activity against aspergillus, but they aren't recommended as monotherapy at this time, so we would use them potentially in combination with another agent such as voriconazole or amphotericin if somebody was failing monotherapy or was refractory. They do have some pertinent adverse events as a class. Patients can experience a histamine-related infusion reaction, so you can see some flushing, itching, maybe a little bit of warmth to the touch. However, this is an infusion reaction, not an allergic reaction, so we can slow down the infusion. We can medicate with an antihistamine or some acetaminophen to help out, and really it's not a contraindication for patients to receive these agents in the future. These can be potentially hepatotoxic, often including an elevation in bilirubin as sort of their hallmark presenting toxicity of hepatotoxicity. The next antifungal agent that we'll cover is terbinafine, and this agent you'll be likely to see exclusively in the outpatient primary care dermatology type setting. It's available orally and topically, and its primary indications are to treat nail fungus, onychomycosis, as well as certain tinea infections. One thing to note is, especially for the oral formulation where you're going to have systemic absorption as compared to the topical where you should not have too much systemic absorption, but avoiding the oral, especially with patients who have hepatic impairment or who have renal impairment with estimated creatinine clearances of less than 50 mils per minute. In terms of the adverse drug reactions, again, these will be more common for patients who are taking it systemically via the oral route as compared to the topical preparations, but headache is relatively common. More rarely, you can see hepatic injury, DRESS syndrome, and myelosuppression. If you have someone who's on oral therapy, those are ones that you would want to definitely be monitoring for. There are a couple of agents that I consider beyond our scope for this course. If you are going to be landing in a practice setting where you're using amphotericin B products, I'd encourage you to become familiar with them, IV only, so typically used in more of the acute care setting. There are some monitoring parameters in terms of monitoring patients for nephrotoxicity, monitoring for hypomagnesemia and hypokalemia, and just knowing that there are lipid-based and non-lipid-based products that are dosed differently from one another, so you have to be aware of the dosing differences. And then flucytosine is an agent that's used in combination with amphotericin B to treat certain infections. You should never see it used alone. It is very rarely used, again, due to its limited scope, as well as the potential for it to have neurotoxicity, nephrotoxicity, potential myelosuppression, as well as elevated LFTs. So that's an agent that I won't hold you accountable for on any of the testing related to the course, but should you see it, you can recognize it as an antifungal agent. We're going to shift gears now and talk about the antivirals, and as I alluded to earlier, we won't cover those used to treat HIV or hepatitis C. So when I talk about antivirals, again, we're sort of going to classify them by spectrum of coverage. So there are some that we would consider most useful to treat herpes simplex virus infections. And those are acyclovir, which is available IV, orally, and topically, valacyclovir, which is a prodrug of acyclovir, and famciclovir. Their spectrum includes herpes simplex virus 1 and 2, and they have okay activity against varicella zoster virus. If the decision is made to treat someone with varicella zoster, these are the drugs that you would most likely be using, with the emphasis typically on valacyclovir. In terms of some practical clinical issues for these, there's a notable ADR, adverse drug reaction, for all if they're given systemically, and that's nephrotoxicity. So typically this is with more IV route, higher dose acyclovir that you're going to see this. And it's an increased risk if patients are taking concomitant nephrotoxic agents. It can result from an acute interstitial nephritis or crystallization. So for any of these, whether they're being used inpatient or outpatient, if the patient is taking them systemically, either IV or orally, we want to ensure that they're adequately hydrating. So advise them to drink plenty of water in the outpatient setting. And as mentioned, this adverse reaction is most commonly seen with higher doses in IV acyclovir therapy. They should also be dose adjusted for your patients with renal dysfunction. Then there are agents that are used to treat cytomegalovirus, or CMV. So the first line in prophylaxis agents that we'll be talking about are ganciclovir, which is the IV formulation. It's also available as an ophthalmic topical preparation, and valganciclovir, which is the oral agent. So you can already see that these are sort of look-alike, sound-alike agents to acyclovir and valacyclovir. So it's important to maintain that distinction as you're looking at these agents, recognizing that their scope is different. Acyclovir and valacyclovir do not cover or should not be used to treat CMV infections because they don't have that within their scope. If you look at the bottom, the spectrum for the agents that we're talking about here, ganciclovir and valganciclovir, CMV is their primary indication. They do have spectrum coverage against herpes simplex and varicella zoster. The reason we don't use these first line for treating those is you'll see on an upcoming slide, these are associated with more toxicities than acyclovir, valacyclovir, and famciclovir. So if you do have a patient who has CMV and concomitant HSV that you're treating, you shouldn't need to add an agent if they're on ganciclovir and valganciclovir, as those should have the spectrum for the HSV as well. If you have someone who is on acyclovir or valacyclovir to treat HSV and they come back CMV positive, you will need to make a change because, again, I'm overemphasizing it, but I think it's the take-home point because of the look-alike, sound-alike nature of these drugs. So commit these to memory and make sure that you recognize the differences. Beyond the scope of our discussion are foscarnet and cidofovir, very rarely used, used for treating resistant infections and used primarily in the acute care setting due to their high level of toxicities. So some practical clinical issues for ganciclovir and valganciclovir. Again, the reason that we don't use these more widely or simply for HSV coverage is due to their notable adverse drug reaction profile. Myelosuppression is seen with some frequency. So for patients who are on these agents, we should be monitoring their CBC while they're on therapy for a regular basis. They do have some significant GI side effects, and that's primarily manifested as diarrhea. The issue with this is that sometimes CMV infections can be located in the GI tract, and so these patients may be having diarrhea from their disease state, which can actually get a little bit worse up front from their therapy. So it's not necessarily a clinical failure if their diarrhea increases when we start these treatments for CMV, if the CMV is in the gut. And we can see drug fever with these agents as well. Now we're going to shift our attention to the antivirals that are used to treat influenza. The agents that are approved for this and recommended for this indication at present are only the neuraminidase inhibitor class. Years ago, we could use amantadine and rimantadine to treat influenza. However, due to increased resistance rates with those agents, they're no longer recommended for influenza treatment. The two that we'll focus on are oseltamivir, brand name Tamiflu, which is available orally, and zanamivir or Relenza, which is available as an inhaler. There is an IV preparation that was first introduced into practice during the 2009 pandemic H1N1 of swine origin outbreak, and that's beyond the scope. Again, it's a very specialized situation and would only be used in the acute care setting. So I wanted to show you what the zanamivir Relenza inhaler device looks like for those of you who may have never laid eyes on one. And the reason that I'm going to show you this is going to come full circle. Obviously, I want you to understand from the patient perspective, but it also comes into play when choosing between zanamivir and oseltamivir for some of our patients. So you see that it's actually what they call a discaler, and it has a silver medicine disc that has blister packs that are filled with powder. So when you slide that medicine disc into the inhaler, so into the tray essentially where that dark brown wheel is, you insert that then into the inhaler and into the device, and then one of the blisters is punctured by a needle, and that releases the medicine so that the patient can inhale it through the mouthpiece. And then when they take their next dose, they rotate that disc and do the same thing and repeat the procedure over again. So you can see that there is a need to have some manual dexterity and to be able to understand how to manipulate this inhaler device for the patient to use it effectively. In terms of practical clinical issues with these agents, the zanamivir inhaler preparation, the powder contains lactose, so you want to avoid in patients with true lactose allergy, not like a lactose intolerance, so people who have to take some dietary supplements so they can eat ice cream, that's different. But if they have a true severe lactose allergy, then we should avoid this. I think the biggest issue with zanamivir clinically is the issue of potential bronchospasm. So this inhaler can induce a bronchospasm in patients, and so we recommend, or actually the labeling recommends, that it not be used in patients with underlying lung disease. So if you have an asthmatic, someone with severe reactive airway disease, or COPD, you would not use zanamivir to treat influenza in that patient population. Again, as I mentioned, you need to assess the patient's ability, both cognitively and from a hand-eye coordination element, and whether they can actually manipulate the device and use it effectively. And it's not for oral administration, so never say never, but one of the things the pharmacist will hopefully be talking to them about is that you don't just pop those blister packs open and eat the powder or put it in water, dissolve it, and ingest the powder. It is meant for inhalation only. With oseltamivir, renal dose adjustment is required, so you can look that up if you have somebody who has renal dysfunction. And when this drug first came to market, there was more concerned with what they called transient neuropsychiatric events. So patients who had delirium or had self-injury. That really was primarily reported in early post-marketing studies in Japanese pediatric patients. There have been subsequent studies analyzing this that have shown no difference in treatment and placebo arms. However, due to those early studies, the FDA does still have a recommendation to monitor for these in the prescribing information. So just so you're aware that it's on your radar. I include this table because more than even remembering the fine detail of this for your lifelong learning, I wanted to introduce you to where to find this information every flu season. You should definitely go to the CDC recommendations annually. They change based on the circulating strains of influenza and potential resistance, etc. But if you see up here on the top corner, there's a link to the CDC webpage, or you can go to your web browser and essentially search for CDC influenza, and it'll take you to the homepage. But there's some great information there, and many of them are in summary table form that makes it very easy to read and comprehend. So we're going to walk through a couple of key points with respect to oseltamivir and zanamivir. You can see that both of them are indicated for treating influenza A and B. And the difference, though, is that there are some age-related limitations. So for treatment, oseltamivir can technically be used at any age. Obviously, if you're dealing with a very, very young infant, you'd want to be working with a pediatric specialist for that. For chemoprophylaxis, so post-exposure prophylaxis, it's recommended for patients 3 months and older. There really are no populations that it's strictly contraindicated in, and you can see a few summary reports over here of some of the adverse events. So you think any age for treatment, 3 months and older for prophylaxis. For zanamivir or Relenza, it's recommended only for patients 7 years and older to treat, or 5 years and older for chemoprophylaxis. Younger children are likely going to be more unsuccessful with using that inhaler device. While it's not contraindicated in the extreme elderly, again, I would put that nugget in your brain of assessing whether someone can manipulate the device effectively. And then again, this summarizes the big concern that it shouldn't be used in patients with underlying lung disease. So who should receive these agents? Well, clinical and observational data from many studies show that early antiviral treatment for influenza can shorten the duration of fever and illness and reduce complications and shorten the duration of hospitalization. It's not necessarily a highly impressive reduction in disease burden in terms of duration. Usually it shortens the duration by about a day. But if you think of that from an economic impact, one missed day of work, one missed day of school, one missed day that the parent has to stay home from work with a child, etc., that does have a decent economic burden associated with it. So currently the CDC recommendations note that antiviral treatment is recommended as early as possible for any patient with confirmed or suspected influenza for these 3 following patient populations: those who are hospitalized, patients who have severe, complicated, or highly progressive illness, or those who are at higher risk for influenza complications. So your immunosuppressed patients, patients with underlying lung disease, etc. Treatment should not wait for laboratory confirmation of influenza. One of the nice things that has happened in the advances of influenza testing are the rapid point-of-care tests. So often in the outpatient clinic setting, a viral swab and a rapid point-of-care test can be performed to give the clinician some guidance to help choose whether or not the patient should be treated with an antiviral. Those aren't 100% sensitive and specific, so there is some potential for false negatives, but it is another tool in the treatment arsenal. But bottom line, if a patient is presenting with an influenza-like illness and clinically you think it's influenza and there's a lot of influenza circulating in your area, it's the season, so to speak, don't wait for that lab value, that send out especially, to come back before you decide to treat. The CDC also recommends that antiviral treatment can be considered. So not as strong as the recommendation on the previous slide, but it can be considered for any previously healthy symptomatic outpatient who's not at high risk with confirmed or suspected influenza on the basis of clinical judgment, if you can initiate treatment within 48 hours of illness onset. And I underline that because I think that's a key point. If you have someone presenting 4 to 5 days into their influenza illness, starting the therapy at that point really has a little clinical utility because their disease course is already somewhat, at least halfway, if not more, progressed. And so if that patient isn't someone who would fall into the category of getting admitted, for example, or doesn't meet the high risk category, then it doesn't really pay to treat that patient at that point. But if they present a day after the onset of symptoms, that would be a clinician and patient discussion and decision on whether to treat with the antivirals in the outpatient setting. In terms of chemoprophylaxis, so what this is someone's exposed to influenza, and you want to use the antiviral agent to prevent them from getting influenza from that index case. We know that chemoprophylaxis, say that 10 times fast, with antiviral agents is 70 to 90% effective. The CDC currently recommends against widespread prophylaxis because the fear is if we use these or overuse these agents, we really don't have anything else in our arsenal for treating influenza. So we want to avoid selective pressure and resistance developing. It's not generally recommended if over 48 hours has passed since the patient has been exposed to the index case. And really, there are certain targeted populations that are likely to benefit the most. So high-risk populations, again, those underlying lung disease people, immunocompromised patients, elderly frail patients, those folks with confirmed exposure, patients who are unvaccinated, and as part of the prophylaxis evaluation, we should be vaccinating those patients at that time as well, or residents of institutions during an outbreak setting. So places like nursing homes, for example, if there's an outbreak within that cohort of nursing home patients, it's probably advisable to prophylax those just because you're in close quarters. Again, you can see the link at the bottom, and annually you can access the CDC guidelines and make sure that you're following the most current recommendations for that flu season. So this slide summarizes the dosing regimens for oseltamivir used for treatment or chemoprophylaxis. And I put boxes around the differences to help highlight them for you. You can see that for treatment, we treat for 5 days. For chemoprophylaxis, we administer the drug for 7 days. The reason for that is if you're presenting with an exposure, sort of the incubation period is within that first 48 hours. So we give you that 48 hours plus the additional 5 days. So that's kind of the rough calculation of why it's 5 versus 7. You can also see a difference in the frequency. So for treatment doses, you'll see it administered twice a day versus chemoprophylaxis doses once a day. So again, you can look this up, but I think it's important to recognize that there's a difference in both the frequency and duration of treatment, whether you're using it for treating active disease versus chemoprophylaxis. Likewise, with zanamivir, the treatment and prophylaxis length of therapy are the same as with zanamivir. And again, it's twice daily versus once daily. And you'll note that each dose for zanamivir is 2 5-milligram inhalations. So 2 of those little disc bubbles is equivalent to 1 dose. So one of those discs with the 4 bubbles is 1 day's worth of treatment dosing of zanamivir, or 2 days worth of chemoprophylaxis dosing of zanamivir. So in summary, just like with the antibacterials, for the antifungals and antivirals that we discussed, differentiating spectra, adverse effects, and patient-specific considerations can help you in terms of selection and monitoring therapy. And I want to leave it as a take-home point with you that one of your public health responsibilities moving forward would be to annually read the CDC recommendations for influenza antiviral use. Not only the CDC, but each state typically has an influenza page. You can usually subscribe to viral circulation reports from your state Department of Health, and that way you know what's circulating typically down to the county level at your state, so that you have a better idea as a clinician of what's going around. So again, thank you for your attention, and please reach out to me if I can assist you with any questions about the content today.